What's going on, everybody? I'm going to give you a bit of an overview on thoracic spine and rib manipulations in preparation for your upcoming lab. So in general, our objectives for this pre-lab material and also the lab itself will be to understand the osteo and arthrokinematics of the spine, identify physiologic implications that lead to the classification and treatment of patients that will benefit from this treatment, understanding what the indications and contraindications are, and then also being able to perform the skill, position the patient and clinician appropriately, deliver the correct amount of force, and also comprehend the role that regional interdependence plays in this region of the spine as well. So a brief overview of some joint mobilization concepts right now will likely agree with much of the content that you've reviewed in prep for the lumbosacral lab last week. But as we look specifically at arthrokinematic and osteokinematic motion, the main considerations here and why this is important for joint mobilizations is being able to understand how arthrokinematic motion affects osteokinematic motion. So our arthrokinematic is going to be the motion that we feel. It is an involuntary movement, and it can be referred to as the motion that occurs on the articular surfaces of the joint. So we think about the rolling and gliding and translating of those joint surfaces. And this movement is going to be our precursor for our osteokinematic motion, which is the motion that we see. So that's more global joint motion, whereas the arthrokinematic is specific to the joint surfaces. When we look at what we want to try to do with joint mobilizations and manipulations, our goal is to try to normalize joint positioning and joint movement, and being able to influence and restore normal tonal balance three-dimensionally around the joint helps to reduce soft tissue restriction and then promote extensibility, helps to restore normalized range of motion and increase synovial fluid movement throughout the joint. It also can increase the sensory input through the nervous system in the area to help mitigate pain as well. So we want to understand that there are some differences between your non-thrust and thrust joint mobilization. We're going to focus here on the thrust mobilization, or joint manipulation as we'll refer to it from moving forward. But we understand that we're going to deliver that same type of force as we did during the lumbar lab, but just on a different joint and in a different treatment plane, with our goals being to try to exceed the pathologic barrier put on the joint with that nice, forceful, sudden increase in joint range of motion relative to that pathologic restriction. We know that if we're not able to move beyond that pathologic barrier, that there's not an ability for us to accomplish that grade 5 joint mobilization, since our grade 4 really works up to that pathologic restriction. So we do need to really emphasize our ability to identify and appreciate what that end barrier point is in that range of motion as we assess from the pathology, because that'll truly give us our ability for a grade 5. We do consider our contraindications, which focus mainly on integrity of the joint itself. So by that I mean any imperfections or breakdowns of the bone, whether it be with frank or stress fractures to the area, or general medical contributions that can contribute to that by way of bone mineral density issues, autoimmune disorders, cancers, pregnancies, and then also instabilities or hypermobilities in the joint, and vertebral artery insufficiency are going to be our big considerations there from a safety perspective. Indications are a bit more obvious, obviously looking at restricted range of motion, dysfunctional movement patterns, and pain. And that can be local to the thoracic or rib region, but also considering regional interdependence here, looking at the shoulder, the neck, the rib if we're at the thoracic spine, or down the chain, are going to be big considerations in this region of the body specifically. We want to consider all the degrees of motion that are freely accessible in the spine. So understanding that it is a 3D plane of movement through the spine in the sagittal coronal and transverse planes. So when we position the patient, we do want to consider all those degrees of freedom. When we look at the kinematics here, arthrokinematically in the thoracic spine, very similar to the lumbar spine, in which we expect there to be uniformity in the opening and closing of the bilateral facet joints as we flex and extend. So as we flex, we expect uniform opening of those joints, and as we extend, we expect uniform closing of those joints. And then looking at rotation, for rotating to the right, for example, we would expect there to be right side facet joint opening with left side facet joint closing. And with lateral flexion, it's the inverse of that. So it would be ipsilateral facet closing and contralateral facet joint opening. So that's important to think about when we look at dysfunctional movement patterns. We do want to understand what's happening at the joints and what the expected arthrokinematic motion is. So when we do observe an osteokinematic abnormality, we'll be able to articulate what the arthrokinematic contributions are there. And with that, you consider what the contributions could be that are causing that, whether it be a specific joint dysfunction, improper or acquired faulty movement patternings, or soft tissue contributions there. And then in the thoracic spine, the ribs play a big role in that. So looking at the thoracic vertebrae, what's important to note in terms of our inspection is going to be the size of the spinous process, which is going to be much longer. So when we do identify our spinous process, we want to be able to realize that as we palpate our other structures at each segment, we do need to migrate coronally to be able to find the facet and transverse processes for that vertebrae that we're on, just because of that size of the vertebrae, and then understanding we have that about 15-degree offset angle there from perpendicular to the ground line for our facet joint surfaces there. So as we apply our glides, specifically our posterior to anterior glides, we need to consider that 15-degree angle there. So we can get that nice joint translation. So you look at inspection for the thoracic spine itself. My landmark that I like to shoot for is if we're on that thoracic spinous process, we know that our transverse process is going to be just about 1 thumb width lateral from that spinous process, a bit coronally, as I mentioned before. Now, what's unique here, as I mentioned just now, is the integration of the rib and the costovertebral joint, which is specific to the thoracic region. So this is going to be an implication for obviously our palpation guided assessment, but also considering the influence of the rib in our movement of these segments as well. So we can see here that there is multiple attachment points here from the rib onto the thoracic vertebrae. But what's specific that I'm going to highlight here is going to be the arthrokinematics of the rib, which is unique to the section of the ribs that we're looking at. And this is because of the attachment sites relative to the costochondral attachments, but also the actual costovertebral attachments. So as we look at more of our true ribs, our 2 through 6 here, excluding the first rib as it's its own animal, ribs 2 through 6, they move in more of what's referred to as a pump handle motion. So the rotation on the image on the right, you can see it's rotating in movement that looks similar to like a spit that you would expect to roast a pig on an open fire on. So we get that rotation movement there that really moves in that AP direction. Looking at the lower ribs where they are a bit more floating, our 6 through 10, we're going to see a bucket handle rotation. So imagine the handle on like a bucket that, or a bucket that you would take on the beach as a kid to make sandcastles, right? That kind of bucket handle rotation. So contributing more into like a rib flare position. So a lateral movement there from that rib, those rib joints. Now, these are important to consider as we look at the kinematics of the joint in relationship to the thoracic spine. So the rib is going to move independently as we breathe, but it's also going to move reciprocally as we move our thoracic spine. So if we look at rotation specifically, for this example, if we talk about right rotation of the thoracic vertebra, we expect there to be right rib external rotation and left rib internal rotation. You can see in the image there on the right as we look at that caliper rotation there. And now that's just so that that rib can rotate to accommodate the movement of that thoracic spine. Now, if we're going to talk about side bending, we're going to see some shifting in the anterior to posterior direction. So we would expect to see for right side bending of the thoracic vertebra, we would expect to see the right rib moves a bit anterior and the left rib conversely moves a bit posterior. Now, if we relate that back to what we expect to happen at the thoracic spine orthokinematically, we understand that as we rotate with the thoracic spine, we're going to get that opposite motion in our facet joints, and then that same concept there with lateral flexion in terms of opening and closing. So we do want to think about that in the context of the rib, because the ribs and the thoracic spine are married as they move. And inspection here, similarly to the transverse process, our junction for our rib there is going to be about 2 thumb widths lateral from the spinous process centrally. So as we palpate, that's our kind of landmarks that I use to help distinguish what area I'm really over there. And then we'll get into our inspection and our actual treatment applications more when we're in person together. And we'll review specifically how to sweep the region, how to deliver our thrust techniques, and how we differentiate the different techniques for the thoracic spine and the ribs.